Yeah, the second case is a 58 years old female patient who presented to us in 2013. Her past medical history reveals a myocarditis in 2001, which is not further specified, so we don't know anything about that. She has had a non-ST segment elevation myocardial infarction in 2010. At that time, there was a lesion in the second diagonal branch, for which she had a balloon angioplasty. In the follow-up, she had a myoview which showed no evidence of ischemia and a slightly reduced ejection fraction. Risk factors are smoking, 40 pack years, and a positive family history for cardiovascular diseases. As such, she presented to our department with heart failure, actually the first signs of heart failure. On the echo that was made, we saw that the left ventricular function had decreased with an ejection fraction of 25%, and it was also dilated with an end diastolic dimension of 76 millimeters. She had moderate to severe mitral regurg and also tricuspid regurgitation at that time, and signs of elevated pulmonary artery pressures, as can be seen here. In laboratory measurements, her pro-BNP was also elevated. She underwent a coronary catheterization, which showed no evidence of new coronary artery disease. The right cath showed that she had lower saturations on the caval veins, and also, as already expected from the echo, increased pulmonary artery pressures with a wedge pressure of 28. So she was installed on heart failure medication and sent home to be re-evaluated in the outpatient department 1 month later. And when our cardiologist saw her again, she was still in New York Heart Association Class 3 heart failure. This is her physical exam, so heart rate of 57, low blood pressure, stable weight and no signs of edema. The ECG showed a sinus rhythm with a widened QRS complex with a left bundle branch configuration. Her pro-BNP level had decreased a little bit, and also her left ventricular dimension and ejection fraction had improved a little bit. There was still a moderate to severe mitral regurg and still a moderate to severe tricuspid regurgitation. So the first question that I would ask you is, considering this patient, what would you think to be the next treatment step for her? So she has refractory heart failure with a reduced ejection fraction of a non-ischemic origin. Would it be to add digoxin? Would it be to add ivabradine? Would it be to consider the options for cardiac resynchronization and give her also an ICD? Would it be to refer her to the surgeon for mitral valve surgery, or again to the surgeon for heart transplantation or a ventricular assist device? So we will give you some time to consider all these alternatives. Keep in mind the heart failure guidelines, which are actually quite clear, providing the correct answer for this typical patient.
I think we have the results here, Jerry. So what we have is, should I pronounce them now?
Yeah,
or?
please.
Yeah.
Yeah.
So we have like 5% at digoxin, 8% at ivabradine, 67% CRTD, 20% mitral valve surgery, and 1% would consider heart transplant or VAT.
Okay, that is, I think, a good result. If we again look at the heart failure guidelines, the ESC guidelines 2016, we can see that there is indeed an indication for both digoxin and ivabradine, but they are very limited, those indications. The same actually goes for LVADs or cardiac transplantation. And indeed, the first thing to do in this patient, because she is still symptomatic and is already on optical medical therapy with a widened QRS complex with left bundle branch configuration, would be to evaluate the need for cardiac resynchronization therapy, as you can also see here in paragraph 8.2, a class 1 indication for CRT. So that was indeed performed in this patient, and after 3 months she still showed no improvement, and her case was again discussed in our heart failure team.
Before you continue, this is also a question of one of the people watching. How long should we wait after CRTD resynchronization therapy? 3 months, 6 months? Is there any recommendation, Jerry? What do you think?
I think 3 months is reasonable because the effect actually is an on or off effect, and of course you have to give the patient some time to show real improvement or to really experience improvement. But 3 months is a good waiting time in general.
Okay, thank you.
Thank you. These are the echoes that we saw from this patient, the parasternal long axis view on the left upper side, already showing the mitral regurg. You can see the real swirling regurgitation jet in this patient, involving the whole left atrium. On the right lower side, you can see the four-chamber view, showing the reduced and widened left ventricle with still a well-preserved right ventricular function. This is the regurgitation jet of the tricuspid valve. On the right upper side, you can see how the transtricuspid gradient is increased with evidence of pulmonary artery hypertension. And these are two TOE images, TE images that show the severity of the mitral regurgitation in this patient. You can see the ERO well above 30. Now the second question, would you consider surgery for this patient? So she is on optimal medical therapy, she has a device and still is symptomatic. So would you consider surgery? Several alternatives. No, surgery is contraindicated in this patient. No, because surgery does not improve functional status or survival. Yes, this patient has a class 1 indication to undergo surgery. Yes again, but then this patient has a class 2B indication to consider interventional options, including surgery. So also maybe a mitral clip for this patient.
Okay, so maybe while we are waiting for the results, I have a lot of questions coming in. Jerry, one for you. What is the ejection fraction influencing your decision to proceed for surgery or not? I mean, if the ejection fraction would be too low, and how much would be too low for you to proceed with surgery?
It's a good question. Of course, the ejection fraction is more or less overestimated in severe mitral regurgitation. In the past, we've also done this type of surgery in patients with ejection fraction as low as 9 or 10%. I think those patients are now better off with proceeding directly to a VAD. So I think it's always hard to give a cutoff, but I think under 15 we would strongly consider a VAD. Actually, we will always consider that because the patient gets a tailored approach by the heart team. But the very low spectrum, you can stabilize this patient for 1 or 2 years, but then you will see that they will end up with a VAD or a transplant anyhow.
Okay, and maybe one brief question again. I think there is no real recommendation, but still we will pop up the question. In presence of a significant MR, would you still recommend first to undergo resynchronization for your patient, or would you proceed directly with your surgical intervention?
If there is a wide QRS complex, our heart failure team always goes opts for the CRT first, because it's a good intervention, and you can see a lot of patients are responders to that. So if you can stabilize those patients functionally, you can defer surgery for quite a while in some patients. Yes.
Okay, so let's go to the results.
Yes.
of the questions, or the answer to these questions. We have 70% answer number 4. Yes, this patient has a class 2B indication to consider interventional option, including surgery. And then we have like number 2 and 3 at around 30%, and number 1, 3%.
Yeah. Well, that is indeed. So it must be correct, number 4. And indeed, if you look at the heart valve treatment guidelines of the ESC, you can see that this patient has indeed a class 2B indication to consider a mitral clip, percutaneous edge-to-edge, or valve surgery after careful evaluation for VAD or transplant. So this is a perfect patient to be discussed in a heart team for all options. In the heart failure team, she was again discussed as said, and we decided to go for surgery. Now in Leiden we've been treating patients with functional MR since the year 2000, so almost 20 years now, and we've always used a so-called structured approach. This approach, the slide refers to ischemic MR, but it also applies to non-ischemic functional MR. Only the cabbage part, of course, is then left out. So patient selection and assessment is important. You have to really make sure that this is a functional mitral regurgitation. The structured and consistent surgical approach actually is based on the fact that we use complete and semi-rigid rings, which is important, and we downsize by 2 ring sizes. And I will come back to that later when I discuss the surgery, what that means. Also very important is to have a consistent intraoperative evaluation. And by that we mean that it's not only important to have no residual MR at the end of surgery when you do your TE, but also that you have enough coaptation height. So we always aim for a coaptation height of 8 millimeters or more. So you have sufficient excess coaptation actually to make this a durable result. So the surgery was uneventful. We used a restrictive mitral annuloplasty. Again, we downsized by 2 ring sizes. So if we measure the anterior mitral valve leaflet and we come to a size 32, we go down by 2 ring sizes. So we go down 30 and then use a ring 28. For the tricuspid, we use a normal sized ring, 30 in this case, and we also use an epicardial LV lead as an extra.
Before you continue, Jerry, one question, which is quite interesting, although we don't have an electrophysiologist here at the table, but maybe I can help. How about left bundle branch stimulation instead of classical biventricular stimulation? There are now a lot of studies being conducted where typically electrophysiologists do an examination and they do a His bundle exam, and then they can decide if they can implant the lead around the His bundle or para-Hisian pacing. It seems that would narrow the ventricular complex and would improve the outcome over time. Please.
Yep, very nice addition. Thanks for that question. So again, the coaptation length at the end of surgery is very important. Sometimes it's hard to really assess it during the surgery because of the shadow that you have when you see the ring here and at this time here. But you should really put your cardiologist to the test, and then you'll get the right results. So we are now 6 years further. She is doing clinically very fine. She's in the New York Heart Association class 1 to 2 with medication. And her echo, it's a transthoracic echo, I should say, at 4 years, as you can see below, shows that her left ventricular dimensions have reduced from 72 to 55, and her ejection fraction has significantly improved from 31 to 50. And this seems to be a very good responder to this therapy with significant left ventricular reverse remodeling, which is also sustained after 4 years. The transmitral gradient is low in this patient, so that is often something that people ask. You don't see any significant stenosis? In the majority of patients, you don't see that. And the pulmonary artery pressures are also reduced over time. So functional MR is a type of MR in which the valve is anatomically normal, at least macroscopically, and it is actually caused by left ventricular wall motion abnormalities. And you can have the ischemic version, which is more prevalent, in which coronary artery disease is the base of the disease, and you can have the non-ischemic variant, in which cardiomyopathy of any type can be the leading cause. They have many similarities, but also some differences. I think the main difference to remember or to consider in your daily practice is that patients with ischemic MR can still have some more or less preserved ejection fraction. In the non-ischemic patients, the functional MR always occurs late in the stage of the disease, so they will almost always have low ejection fractions. That's the important difference, I think. Going back to ischemic MR, because we know much more about ischemic than about non-ischemic MR, it occurs very frequently, and about 50% of patients after myocardial infarction can have some severity of mitral regurgitation. It can be dynamic, So at rest you cannot see it sometimes, but when the patient does exercise, for instance bicycle exercise, you can see that it develops because of the wall motion abnormalities. And it is very important to realize that it is associated with a very poor outcome, as is shown in this series by Grigioni. Grigioni also showed us that, well, of course you can easily imagine that this is very bad for a patient because the left ventricle suffers from actually two injuries. It's both coronary artery disease in this case and the effects of the mitral regurg itself. And here you can see that the severity of the MR is really making a difference when it comes to outcome. This was already addressed. There are some differences in assessing the severity or considering some type of MR as severe between Europe and the United States. We won't go into that now again. But it's of course very obvious that there's a vicious cycle in which MR begets MR through left ventricular volume overload, with a consequence of reduced myocardial perfusion and increased wall stress and ongoing left ventricular remodeling.
A question again for both Roman and Jerry. So a patient with reduced ejection fraction, significant secondary MR, should we bring this patient, so no other comorbidity, should we bring him to the operating room or to the cath lab to be treated? Roman.
Well, that's always an individual question to the heart team, I think. And ejection fraction is not everything, so we have to see the whole patient. And I think there can't be a general answer. That would be much too easy.
I think so. I think the advantage that surgery has is when it comes to additional procedures. If you also need to do something about the tricuspid, if you need something to do about the ventricle, etc., then you can do it all in one. But if it's an isolated mitral regurg, you can really make an individualized plan based, I think, on the institutional experience and the patient itself.
Maybe I just can add, if someone has the question for his patient, the best thing would be to send him to a center of the Matterhorn trial, which is an ongoing trial in Germany comparing actually this problem, comparing surgical approach with the MitraClip approach in patients with secondary MR. So this is a very important question, I think.
Okay.
Yeah.
And I think this is a very interesting question as well for you, Jerry. In a post-STEMI patient with papillary muscular dysfunction that can cause MR, what do you recommend, surgery or optical medical therapy?
Good question. I think I think the same algorithm goes that you would first start with medication and then see what it brings, and then surgery. You can also always go for surgery, but I think OMT will be the first start.
I agree. Please proceed, Jerry.
Thank you. So the goals of IMR treatment or functional MR treatment are to reduce symptoms and improve survival, which seems logical, I think. And the targets that we have are the mitral valve and the left ventricle. I think both are equally important, so you have to get rid of the mitral regurg and also do something about left ventricular reverse remodeling. Initiate it and also try to sustain it, because that will eventually affect patient prognosis. So again, the treatment should involve the valve with a restrictive mitral annuloplasty, and in ischemic cases, coronary revascularization. For non-ischemic, the story is a little bit different, of course. So, as I said, we've been doing this for 20 years now, and we've been following these patients, and we have some publications on them. The first series that we examined were, I think, 65 patients, 65, and we showed that after 18 months there was reverse remodeling in the overall patient group, but there were some patients who showed reverse remodeling and some who didn't. And when we thought about the risk factors, we assessed and we found that left ventricular end diastolic dimension before surgery could really predict if patients were to show reverse remodeling. So the 65 millimeter cutoff value was found in this series. And actually a couple of years later, when we had more patients and we looked at mortality, we again saw that this single parameter was the only one that could reliably predict late mortality. So that again brings it back to the fact that the amount of left ventricular remodeling is important in determining outcome. If you look at this from the same publication, if you compare the patient groups, you can see that there is no difference at 5 years when it comes to the amount of recurrence of MR, but this makes the difference. So the reverse remodeling is translated again in survival difference, as you can see here in this diagram. Now this does make sense because there have been several other studies. This is a very interesting study in which Kramer compared about 30 interventional studies using drug therapy in patients with heart failure. And as you can see, he compared survival or outcome differences here on this axis to the absolute difference in change from baseline and diastolic volume. And those in the left lower corner were the positive studies, so those who showed a benefit in terms of survival. They also showed a decrease in end diastolic volume from baseline. And those who did not show a difference or even worse outcome, they also did not show a change in, or at least not a reduction in end diastolic volume. Again, it's displayed here in a slightly different fashion. So again, also from drug therapy trials, we can see that functional mitral regurgitation interventions that really affect the ventricle are those who are more likely to provide long-term benefit. This also is shown by one of the CTS-NET trial, the cardiothoracic surgical network trials. The American studies that were randomized 250 patients. In the moderate IMR trial, they randomized them to undergo either isolated CABG or CABG plus mitral valve repair. And the one that is shown here is the severe IMR trial, in which patients were randomized to undergo either a chordal sparing mitral valve replacement or a mitral valve repair. And the primary endpoint was, again, left ventricular end systolic volume at 12 and 24 months. And you can see for the replacement group that there is a slight reduction in end systolic volume index, about 10% at 2 years. And for the repair group, it's about 14%. So there was no difference in the primary endpoint, whether you do a replacement or a repair. And there were also no differences in secondary outcomes, survival and clinical status. There was one important difference, which you can imagine to some extent. In the repair group, the recurrence rate was very high. It was 33% at 1 year and almost 60% at 2 years. So these are very high numbers, which are not seen in any other study. Maybe we can comment on that later. But the interesting thing is that even if you have 60% mitral regurgitation compared to almost zero in this group, of course, after replacement, you can still see that this does not affect the primary endpoint, neither does it affect the secondary endpoint. However, if you consider the repair group and you split them into those who had a successful mitral repair, so without any mitral regurgitation at 2 years, and those with an unsuccessful repair, so those who showed mitral regurgitation, and then look again at the primary outcome, you can see that the primary endpoint, you can see there is indeed a difference. In those who developed MR and systolic volume index did not change. In those without mitral regurg, there was a 30% drop in in systolic volume index. So again, if you have a repair without mitral regurgitation, compare that to a replacement without mitral regurgitation, you can see that these patients do better. So that's an important point to find. And if you consider that, you could say, well, maybe treatment of MR is a futile therapy if it does not lead to reverse remodeling, if you consider the overall group. And in that case, repair with less recurrence may not be the answer. Again, percutaneous mitral valve replacement in such a setting will also not do much better. However, we have to realize that some patients, as we saw on the right spectrum, do really well with a repair. And that, of course, has to do something with selection. And again, the answer will somewhere be in the amount of left ventricular remodeling. And again, the ability of the left ventricle to show reverse remodeling. So that will be the future goals for the heart failure team, to identify patients with good chance of left ventricular reverse remodeling. Partially the answer will lie in simple measurements of volume and dimensions. more complicated, of more sophisticated measurement of geometry, also reflecting the amount of left ventricular remodeling, and again, other things like viability and contractile reserve may provide the answer. And again, also for the heart failure team, we have to be aware of, and maybe also be very aggressive in giving these patients optimal treatment. Also looking at the tricuspid valve, also looking at the ventricle itself when necessary, and also taking into consideration the presence of arrhythmias such as atrial fibrillation. So some take-home messages for you. Heart failure treatment is indeed a team approach, as we've seen today. If we do believe that left ventricular reverse remodeling is the key to success, and I think we've seen some evidence of that, then we should still aim to treat both the mitral valve and the left ventricle. Surgery does require consistency in the approach. You have to have one approach and stay to that. And again, these patients should have an individualized treatment by a dedicated heart failure team. Thank you.
Thank you, Jerry. I think one question for you. A heart failure patient with preserved ejection fraction, significant mitral regurgitation due to ring dilatation, is there an indication for operative annuloplasty?
If this patient is indeed on optical medical therapy, I think yes, for sure.
Okay,
yes.
Thank you. Another quick question. Maybe, Roman, you can address this question. Should Entresto be included on the definition of optimal medical treatment?
Absolutely. I mean, if you look at the current treatment algorithm, Entresto is part of the further down treatment algorithm with mortality benefit. And what is very interesting, that two weeks ago, the PRIME study was published, which is overall the first drug trial with secondary mitral regurgitation as an outcome. And it compared Entresto in just 120 patients, but it compared Entresto with valsartan as a comparator. And indeed, Entresto significantly more improved mitral regurgitation quantity than valsartan. So it is absolutely.
Okay, thank you. I have another question, a little bit odd question, but Jerry, maybe not to you as a surgeon. Any role of pulmonary artery banding in bad mitral valve? You have any experience on this?
I would ask that to our congenital surgeons. Pulmonary artery bending will for mitral valve regurgitation. I don't really see how that would.
Me neither. I have never heard of it.
Something you will reduce flow to the lungs, but that does not affect the severity of the mitral, in my opinion. No.
Okay. So thank you for these nice presentations. Maybe we have some general questions to discuss, both for Jerry and Roman. Experience as a surgeon, experience as an intervention cardiologist. How important is this? Maybe, Jerry, you can start.
I think experience is very important. In general, first of all, again, this is not only a surgical piece of art, or how you would call it. It's the complete package. You have to have a dedicated heart failure cardiology team. You have to have good echocardiographers. You have to have good anesthetists, and also a good ICU to have a good outcome. Coming back to the surgery, I think indeed also experience is very important. Putting in a ring is not a very difficult procedure, not like organic mitral valve disease, for instance. But there are also some things that you have to pay special attention to. You have to really reduce the annulus, so you have to take smaller bites. And you should not be afraid, again, to use a very small ring, like size 24. And I think that is one of the reasons that we've seen such a extremely high recurrence rate in the American trials, that those surgeons sometimes were relatively inexperienced. If you see the number of centers, it was 22, so there were some centers in which they only do 2 patients. And the mean ring size was like 28. Compared to in our center, the median ring size is 26. So some surgeons are really afraid to use small rings. There's no reason to be that. but for that you have to have experience.
So definitely high volume centers.
For sure.
We are in favor of. Roman.
I mean, I can confirm the same thing. Mitral clip procedure, I think, is one of the more complex procedures in cardiology overall. And there are some data from the beginning in Germany showing that learning curve of about 50 procedures is very helpful to improve the technical success. We have some data from the German mitral clip registry showing that low volume centers have some slightly lower efficacy, technical efficacy, compared to the high volume centers. And I think the best example supporting this expertise issue is the comparison of mitral FR and COAPT trial. And in France, the interventionalists had almost no experience with the procedure. The Americans had at least some experience with the procedure, and the differences in safety and technical efficacy were dramatically, I think, almost twofold difference between both, despite proctoring by the company, which was present in both trials.
Mm-hmm. There is also a question, maybe I can address the question about can we use Carlin device, so that's a percutaneous implanted kind of semicircular ring in the sinus coronarius. I think we have some results. The results don't seem too bad, but I think the population being treated with this kind of device is still too small compared with the mitral clip, where over 80,000 people around the world have been treated. So we have still some minutes left. Maybe it's good to talk a little bit how mitral FR and COAPT will influence our daily practice. Maybe very briefly, Roman, how did the results of mitral FR and COAPT help you in identifying the ideal patient to treat, and I mean interventional-wise?
Well, that's a difficult question. After the first publication, I think what will be very helpful will be further sub-analysis of both trials. I mean, what we can just do at the moment is following more or less the criteria, inclusion criteria presented in COAPT, because we know that these people have a clear prognostic benefit. So I will overall follow this criteria, and I think the most important inclusion criteria are the exclusion of severely dilated left ventricles and the confirmation of really severe mitral regurgitation defined, for example, by ERO. And maybe in the future we have a kind of ratio between ERO and left ventricular volume, which will give us an excellent cutoff. Okay. But this needs to be confirmed in further trials.
Thank you, Jerry. I'm going to address another question which has been popping up twice. So for our colleague who has been popping up this question, end-stage heart failure patients, severe MR, how to select between mitral clip, LVAD or optical medical therapy?
Very interesting question. That happens, well, not every day, but on a weekly basis in our heart team we see those patients. And considering again mitral clip versus mitral valve surgery, I think we take into consideration if there needs to be anything extra done. Considering mitral valve surgery and VAD, that is not so easy to answer. We have the VADs in our own hospital as destination therapy, so for patients who are deferred from cardiac transplant. And there is, those patients generally are those who really have what we think a poor chance of recovery of the left ventricle. But that is something that we decide as a team, taking into consideration MRI, dobutamine stress, etc., etc. So there are several factors that we weigh. But again, the VAD is also not a panacea. I mean, having a VAD is also something that the patient limits the patient in some way in his function. So that requires a case-by-case evaluation by a dedicated heart team. It's very difficult to give a very strict and straightforward advice.
So we are almost at the end of this session, and this is very nice. Some of one of our colleagues is saying thanks to both of you. It's very important that mitral clip is indicated only in patients with correct medical therapy treatment. So that would be a nice way to end this session, I think. So, ladies and gentlemen, we are now approaching the end of the webinar. I would like to close this session by reminding some key messages for your daily practice. First of all, we should try to identify patients with heart failure and secondary MR already in the early phase of the heart failure vicious cycle in order to be able to intervene timely after optimal medical therapy has been established. Secondly, both surgical and percutaneous approaches should be discussed in a typical heart team setting. And finally, the heterogeneity of the typical population should be under our attention when we apply the current guidelines, and we should be aware of the limitations of these current guidelines. We will now close the webinar, and thank you all for watching. Especially I want to thank Professor Fitzer from Cologne and Dr. Brown from Leiden to be here today. Thank you very much.